and recommendations. So basically, the study hypothesis was looking at the fact that peer influences in adolescence, especially when young people are involved in educating peers, that is people of their same age, same gender, equal status, and so in terms of rank in society, they are able to actually model healthy behavior. And this basically then leads to an increased uptake of health services over time. In this case, this particular study is looking at HIV testing. So in this study, the sample involved 2 TVET colleges, as I indicated, in Northwest. And a quantitative approach was used, whereby HIV testing data recorded at the 2 TVET colleges was analyzed. In terms of creating a context for the study, the research was done against a campaign which we call First Things First. And basically, First Things First is a counseling and testing program which is implemented by Higher Education and Training HIV/AIDS program, AIDS. Overall, the objectives of the campaign are to promote regular testing amongst students, as well as to eliminate stigma, and as well as to build capacity within TVET colleges and higher education institutions. If you look at the purpose of the FTF campaigns, the First Things First campaigns, they're aimed at optimizing opportunities for testing for HIV, as I indicated, and screening as well for TB and STI. And they actually contribute to the first and the third goals of the National Strategic Plan, NSP, 2017 to 2022. The first goal being the fact that the NSP is looking at accelerating prevention in order to reduce new HIV and TB infections and STIs, basically to break the cycle. And then the second goal is focusing on the fact that nobody should be left behind, whereby the aim is to reach all key and vulnerable populations comprehensively using a targeted and customized approach. Now, the FTF program, or the First Things First program, was actually introduced to the TVET colleges in 2014, which is about 3 years ago. At that time, in order to maximize or to get the highest number of students to come for testing, incentives were used in the form of USBs, caps, strings, and T-shirts. Now, moving along to the conceptual design of the study, I think it's important that we should define what peer education is with a specific focus on youth. And as I indicated right at the beginning of my presentation, it's basically a situation where motivated young people are able to actually organize educational sessions, whether structured or informal, whereby they're actually able to reach out to their peers in terms of health education. Now, in terms of the theories that are put forward as far as behavior change is concerned in peer education, the one that complemented this study is the participatory theory of education, which was championed by FEAR. Basically, what the theory is stating is that if you have full participation of people in a particular program, it actually results in empowerment, right? And especially if you do that through dialogues, the affected community is actually able to come across and implement come up across with plans and implement a response to their specific problem. In this case, if you look at this process as in a horizontal context, what actually happens is that equals talking amongst themselves are able to actually determine a course of action to influence behavior change. Just generally now to look at some of the benefits that have been identified globally for peer education, it's able to actually positively influence young people's attitudes and knowledge on HIV and reproductive health. And it actually also leads to a decrease of the number of sexual partners that youths have, and it actually also leads to an increase of condom use. And the youth are actually able to reach out and educate others using prepared material in the form of brochures and also distribute condoms. And it also actually results in an increase in community norms about youth and sexual behavior. Okay. I think the slide is very detailed, but basically what this shows is just a bit of research that was done internationally in terms of case studies, which actually resulted or reflected the fact that peer education is actually able to lead to an increase in uptake of health services. I'll just focus on the first one, which was done in 1998 in Zimbabwe amongst factory workers. What was done was that there were two groups that were identified amongst factory workers. In this research, the intervention arm was given HIV testing and counseling as well as peer education. And then the control arm was only provided with the HIV testing only. So basically, the end result was that within the intervention arm where there was HIV testing plus counseling, the number of people that came forward for testing increased, but at the same time, not only did that happen, there was a decrease in the incidence of HIV in the intervention arm. Whereas in the control arm, where there was only HIV testing, you actually realized that there was an increase in the HIV incidence and that the uptake was also very minimal. For this particular study, what I did was that I used a quantitative approach. I used student population that was provided by management from TVET colleges, whereby our teams went and they did HIV testing. And from the data that was captured from HTS registers and consent forms, this is what was then used to analyze and come up with the findings and the conclusions. Now, in this particular case study, I've got College A, which is the intervention arm where there was HIV testing plus peer education. And then I've got College B as a comparison, which is the control arm where there was only HIV testing with no peer education. Now, the data is analyzed from 2014 when the First Things First campaign was introduced to the TVET sector to 2016. As you can see, the blue represents College A. And if you look at the trend line, there's an upward trajectory in terms of the increase in testing numbers from 2014 to 2016. Whereas if you look at the red, which is College B, which is the control arm where there was only HIV testing, you actually see that although there was a slight increase from 2014 to 2015, there was then a decline from 2015 to 2016. I'll explain the data on the next slide. How do I go back? Okay, let me just use the graph to explain this. So what actually happened in College A, where there was HIV testing and peer education, the peer education program was introduced in that college in 2014. And implementation actually then started in 2015. So you'll find that in 2015, the testing numbers actually increased by 417%, from 508 to 2,631. Whereas in College B, which is the control arm where there was only HIV testing, the increase was only 78%, right? And then going forward, you will find that from 2015 to 2016, in College A, the increase continued, even though it was at a slower rate, it increased by 2%. Whereas on the other hand, in College B, there was a decrease from actually 78%, there was a 25% decrease. And the reason for this was that if you look at the increase that I mentioned from 2014 to 2015, College A introduced the peer education program, which they fully started to implement in 2015. As I indicated in my introduction, there was an extensive use of incentives at the beginning. There was an extensive use of incentives from 2014 in a bid to actually try and increase testing numbers or testing uptake. What happened then was that in 2015, use of incentives continued. However, College A, which had the peer education program, actually realized an even greater increase in testing numbers, which came up to about 417%. In 2016, however, what happened is that incentives were taken out of the HATES program. And now students were trying to now encourage students to test for the right reasons, to take accountability of their own health. In this case, College A, which had a peer education program, actually managed to maintain an increase in their testing numbers simply because they had the peer education program which was well functioning, and it led to higher testing numbers. Whereas on the other hand, College B, which didn't have any peer education implementation in place, actually resulted in a decrease in testing numbers. My time is up, but basically, just as a conclusion, I think what is evident from this research is that it confirms the widely documented evidence that has shown that peer education has a positive impact on attitudes and behavior and actually results in an uptake of health services. And this is an indication of the fact that actually biomedical and behavior change strategies can be actually combined and they can have a positive effect on health screening services. In conclusion, what I can say that this finding then provides a credible basis to recommend the strengthening of peer education programs in all TVET colleges across the country, given that they are only 3 years old in terms of introduction, and especially if college management fully engage and take ownership of the program. Sure. Sorry, my time is up, but I think going forward what I envisage to do is that because this research was only based on quantitative analysis, I am going to employ a qualitative approach as well, whereby I'm going to introduce focus group discussions as well as key informant sessions now to actually try and see if I can validate the case findings even further. Thank you.
Thank you very much, ma'am. I'm sorry that time, unfortunately, is our enemy. Shall we quickly then move? We're running short of time. I see my speaker list is filling up, which is good. I'll now ask Mr. Makupule Moshia, who will speak on implementing the men that have sex with other men or lesbians, gay, bisexual, transgender, intersex program at the University of Limpopo, Lessons Learned. Over to you, sir.
Greetings to everyone. I'll be speaking on a program that we had at the university, and this presentation is basically going to be on implementing the men that have sex with other men, lesbians, bisexual, transgender, and intersex program at the University of Limpopo. The lessons learned. Now, to start, I would like to firstly explain what this program is all about. I understand that it wasn't practiced in all institutions of higher learning, especially in the TVETs. The MSM LGBTI program is basically a program for implementing strategies that are going to work to advance issues of the LGBTI community. Now, the MSM LGBTI community is one of the minority groups within our communities, and we believe that it exists even in our higher institutions. This is basically an awareness program for key population, as according to the NSP, with the aim to increase access to healthcare, student services, and overall social justice in higher education. And these were implemented through advocacy, creating incubators of change, through investing in a peer education program and an LGBTI student organization. The intervention activities that we had in the institution, the University of Limpopo, are as follows. We had the empowerment groups. These are basically peer-led support groups whereby students within their own confines spaces, they would then engage on their experiences and encounters as LGBTI students, right? And then we had campus dialogues. The campus dialogues basically would go in this fashion. The students' population being anybody within the community being offered an opportunity to can engage and learn more about LGBTI issues. This is mostly presented by the LGBTI students themselves to educate their fellow students about what LGBTI issues are all about and what they entail. We also had sensitization workshops. This is where we get presenters whom are experts in the field of LGBTI issues to come and inform and educate the student community or the staff community at the university about LGBTI issues. Now, this is the one chance that we get to actually fight and destigmatize, our people through sensitization. We also have community outreach. This is whereby our LGBTI students, within their organization, they go within their community to do basic outreach programs. Now, the difference this time around is because these outreach programs are done by the LGBTI students, we are now given the opportunity to can see that even our LGBTI students, they are humane just like any other person within the community. And just like any other person within the community, they care about their environment that they find themselves in. Then we have the student organization. Prior to this, we didn't have within the institution a student organization that was meant to cater for the needs of the LGBTI students. Through as one of the interventions, we then formulated an organization. We called it the UL Outrage Student Organization. And within that organization, we find that we can attract all other LGBTI students to form part of a community that they can easily identify with. Intervention activities that were meant for staff members include colleagues working together. From the office of the MSM and LGBTI office, we would then have collaborations with the other stakeholders within the university that engage on a daily basis with the students, from the housing community, the security, and all other facets of the university. We're speaking about your health and wellness and your counseling and development officers. We also have the HIC committees within our institutions. These are the people that advocate and mobilize and resources to ensure that there are activities and interventions within our institution. The intervention reach. With all these interventions that I mentioned, this is what we managed as an institution to accomplish. We have, in the period of the 3 years that this program was implemented, we have over 1,300 MSM LGBTI students that attended the peer-led support groups, which are the empowerment groups that I mentioned earlier. Over 17,000 condoms and lubricants packs, and with IEC material within them that were distributed amongst the LGBTI students. We had over 1,200 general staff and students who were sensitized about MSM LGBTI issues. Now, through this, you can understand that there's a shift in mindset from this result. We're having people now understanding or having more knowledge about the LGBTI issues. We also had a minimum. This is over a period of 3 years, a minimum of 60 MSM LGBTI students that got tested for HIV annually. Now, the lessons learned from the implementation of this program, we basically learned that institutional buy-in has to be in the literal sense. In our instance, we basically, what can I say, practice what we preach. In all institutions, you have institutions talking about how they want to transform their institution. But now we only have this in terms of policies, and then we never see it on the ground, whereby students are actually engaged and there are intervention programs implemented. We have, the other lesson is that LGBTI facets are beyond health issues. If you look into your own institutions, you will understand that most of the time when we get to hear about LGBTI issues, it's when there are health interventions involved. It's when we need the introduction of lubricants within our health systems. So we have, from the implementation of this program, we've got to understand that it is beyond health and wellness, these issues regarding, LGBTI issues. Just like any other community within our institutions, there are other facets. We're speaking human rights, we're speaking, social justice. All these other things are not necessarily related to health, but we find that we only look at LGBTIs or consider the LGBTI community when we want to implement our health programs. But we can go beyond that. Now, the other issue that we understood is that there's a high need to occupy spaces and create safe spaces. For instance, we have the issue on gender-inclusive bathrooms. This is something that is practical and can be achieved, and we see this being implemented at the University of the Free State. And we have LGBTI student structures. These are things that are practical, and we can have them, just like we have peer education structures within all institutions. This is something else that we need to do. Within the University of Limpopo, we had our UL outrage. Now we have the LGBTI. The other lesson would be that LGBTI issues or interventions, they are limited to the LGBTI youth community. We are failing to understand that even within the staff community, there is LGBTI, or I can say that within the adult community of our institutions, there are LGBTI community members there, and we need to source or start implementing interventions for those individuals. And then the other issue is on the human resource. We do not see the institutions or our institution in this regard, hiring and retaining members of the LGBTI community. The recommendations in this regard is the institutionalizing or institutionalization of interventions which are result-based, of course. For instance, the MSM program has, the MSM LGBTI program showed us that with certain interventions, we can get results that are positive. Now, if you have such a program, it is important that we keep it and we institutionalize it and make sure that it's formed part of our annual or our permanent program as an institution. Unlike a case of this program whereby it was funded externally through NACOSA, it was after that intervention we see that after that program or after that period of the funding, we now see a lack in terms of the interventions being supported because of the lack of funding thereof. Now, the other thing is we need to research in this regard. My time is up. We need to increase research within this regard so that we can have better interventions and we can have creative methodologies of living within our communities. And then the other one would be, the last one would be the issue of policy writing and implementation. We need to strengthen the transformation offices within our institutions to ensure that LGBTI communities are basically catered for. Conclusion there, it will be that we realize that this program in particular, it frustrates the inclusion of the MSM and LGBTI community within the mainstream health program in our institution. And the last thing will be that there's a continuous need to educate both MSM and LGBTI community, including the heterosexual students, about safe anal sex, as this is one thing that is practiced by all and is the reason why we are having all of these interventions regarding LGBTI as high-risk population within the health sector. Thank you.
Thank you very much, Mr. Mushia. A very interesting intervention indeed. I'm sure the audience will engage with some of the best practice models you have shared with us. I would like to invite now Mr. Melusi Dlamini, who will be talking on a program called Memeza, Shout, Developing Student-Led Advocacy to Challenge Homophobia and Stigma on Campus. Mr. Dlamini.
Good afternoon, everyone. So I'll be speaking today on an intervention that we carried out at the university that I work at, which is the Durban University of Technology. So the premise, and I feel like I have to sort of explain before I start because I don't really I didn't really prepare it in terms of a research structure. So the premise here, particularly starting with the word memeza, it acknowledges that in certain spaces, LGBT youth tend to be silenced. So if you translate memeza, it means to shout, it means to speak loudly, to be audible. So this was about then acknowledging the agency of students, but more than that, then having interventions that are student-led, that are governed by students, and having students take charge of their own circumstances in this regard. So LGBTI persons in South Africa continue to experience various forms of violence and discrimination, and higher education institutions are no exception. This we have seen increasingly throughout the country, and I know there was a story earlier on this year, particularly in a TVET in KwaZulu-Natal, where lecturers refused to teach a student because the student identified himself as gay. So we tend to assume that institutions of education are places in which policy is strong and that where human rights prevail. However, we've seen over time that this is not always the case. So sexual and gender minority students continue to experience marginalization and even homophobic violence. Once again, there are demonstrated or rather documented experiences of students who have experienced homophobia and violence whilst on campus. However, very little evidence of the assertion and promotion of the constitutional rights of LGBT identifying students in South African institutions. So basically what this means is, although most institutions have transformation policies or even have policies that purport to protect students, this does not always filter into reality. So we find that even though policy says something else, the experiences of students demonstrate something else. So this intervention was then about looking at the lived experiences of students, of documenting their journey as they attempted to bring about change in their immediate environment. So the objectives of this intervention was to increase awareness of LGBTI-related stigma and discrimination on campus. It was also to identify and create LGBTI-friendly spaces. Like I'm saying, this was particularly important because policy will say, oh, of course, we don't discriminate, we support. However, when you speak to students about their daily experiences, sometimes you can hear something different. So it was the following objective was also then to recruit and train students to form student alliances. Now, this is beyond just having LGBTI societies on campus, but this was to consciously form relationships that could forge work that would work against homophobia on campus. And then it was also about, the project also sought to engage the wider university community. So some of the things, and this is the important part about the actual intervention. So the methods that we used or that we employed, just maybe to also contextualize this intervention. So it happened, well, I work for the Durban University of Technology, which has 7 campuses dispersed across the province, but we concentrated on one, the Steve Biko campus, which is the main campus, which also houses the major bulk of our student population. And then we also drew lessons from a pilot project that we had done, which initially used only 10 students. So we increased the number of students. We now had 20 LGBTI students, and then they identified and recruited allies on campus. Now, these could be, these had to be people who were in influential positions, whether it was people in student leadership, or it was a staff member, or a person that they felt they could get support from. Then students underwent, as one group now, they all underwent training, which included sensitization, mapping of campus, where we then physically walked around to find out what were the safe and unsafe spaces on campus. Thank you. And then we also unpacked what it meant then to have human rights and what it meant to ensure that these were observed whilst on campus. Students were then asked to document their experiences, as I've mentioned before, and then the students, having a group now that was LGBTI-identified students and non-LGBTI students, they then collaborated throughout the semester on a series of programs. The students developed responsive advocacy initiatives that included, these are the three notable ones. The first one was a campus dialogue series, which was addressing homophobia. These were done on campus and in some of the residences around campus. There were also safe zone workshops. Now, these were held by the students themselves, where they were trying to then speak to other students, peer to peer, to sort of unpack what it meant to be supportive and non-discriminatory whilst on campus. And then the penultimate one, they then had a Day of Pride and Equality, which was an event that was hosted by the students last year, and it was about then increasing awareness and empowering other students. And it was an intervention that was held by both LGBTI and non-LGBTI students. So these are some of the pictures from the interventions themselves. So this is the campus LGBTI society, and they collaborated with some of the influential people on campus. So some of the lessons then that were learned from this intervention. There were reflections, well, the reflections of the students revealed evidence that the project facilitated students' critical thinking and reflection. So some of the things taking into consideration, things like the pre and post evaluations, there were attitude shifts where you could see that students were nervous about being part of this intervention, and you could see a noticeable shift after when people were evaluating and reflecting on their own participation. Thank you. And there was also the creation of supportive and sustainable networks on campus. Here, students were able to then, beyond just working with an LGBTI group, we were now working with non-LGBTI persons to ensure that we don't, because the tendency is to work with the vulnerable population and not also work and not also build support for them beyond that. So this was one of the outcomes, and then there was also demonstrated valuable potential for developing student-led advocacy. So some of the other outcomes were individual empowerment of students in terms of personal challenges and leadership. There was also this also demonstrated the potential of value of student-led initiatives, like I was saying, but particularly dealing with homophobia. Students were also then able, like I was saying, that it also acknowledges the agency of students. They were also able to examine their own actions when on campus, how they could possibly be perpetrators or supporters by silence or by omission. And the project also highlighted the significance of creating spaces for engagement with students outside of the formal curriculum. So in conclusion, the project reveals then the potential to, the project has the potential to be rolled out throughout multiple campuses or institutions, and also then there's the infusion of elements of the project into other existing programs, like, for example, the peer education program, which tends to be rolled out in other institutions as well. There's also evidence gathered from such a project. The evidence gathered from such a project could also be used to develop and amend existing policies. Thank you so much.
Thank you very much, Mr. Dlamini. Our last presenter is Ms. Melanie Mare, who will speak on the topic, Make Your Mark by Leading the Change, an innovative method of addressing HIV information overload at a higher education institution. Thank you, ma'am. they loaded it. Just
Okay, good afternoon. We're from CPUT, and I will be talking about Make Your Mark by Leading the Change. I won't say it's innovative, but I hope you will be able to learn from our experience. Okay, what is our approach? Our institution's logo is creating futures. So we, from the HIV unit side, I say we're creating futures through listening to our students. What do we do? Students are saying, involve us, learn from us, let us lead the change. And that is our approach with the students. Okay, how do we do it? We collect feedback from the students. Where do we get it from? Workshop evaluation forms, conference evaluations, surveys. We have a peer education M&E tool and student assignments. So we get the feedback from the students and we act upon it. Because there's an issue of information overload when we don't basically give when we give too much information. So we're trying to address the overload issue. Okay, this is one example that we use with our peer education tool, that you can see all the different faculty students that participate in our peer education program. And quite interesting, we have quite a bulk of business education, business management and engineering students on a yearly basis. Most of them participate in our peer education program. There you can also see the different activities that students are fond of, especially condom distribution and discussion groups, because they say that is when they have enough time. Then, of course, students are saying to us, don't overload us with too much information. They say, involve us when you design posters. Don't give us too much information. Be short, sweet, and to the point. And don't waste your money with posters, putting it everywhere. Put it at places where we have time to read. Put it where we stand in a queue. Put it where we sit and wait for something, because that's the time when we actually have to listen to you or read. Tell us about new developments in HIV. Tell us about positive stories as well. Okay, what they say they like most about our HIV workshop, the openness of facilitators, student participation. The students want to be involved. They want to participate. They want to be in activities where there's discussions. What they also recommended is give us more time, more activities, more videos, more game sessions. And they say they want snacks and drinks as well, and more breaks in between. I'm sure all of you would agree with that. But we're trying to listen to that. We buy a lollipops or maybe a packet of chips and give them more breaks in between. Okay, and our response is we listen to the students. We really, really involve them, and we try to make our interventions as interesting as possible, and we reward our students. Like our students that came with us to the Youth Leadership Conference are those that actually were very active in the first part of the year, so they deserve to sit here. So they know they wouldn't come if they were not active enough. Okay, and then we involve arts and culture in our programs, and we integrate other health-related lifestyle conditions. I'm going to quickly hand over to my colleague, because there's a 2-minute clip that we want to show you guys. Thank you.
Thank you, Melanie. My name is Nathan, and I'm the peer education officer. And I probably just clicked this button. The next slide. There we go. So the peer education program at CPUT, what we're trying to do enforce within our students and our population is, firstly, they have to go through a recruitment process. And this is you actually recruit vibrant and young people that actually did some effort to be part of the program. So that handpicking of you, our next peer educator, doesn't always work, because if you didn't go through any effort to become a peer educator, you will not give back all that effort. So that is the process that we're following with our peer education program. And then the ways of implementation that we follow is that we do awareness campaigns with them, which they implement and they come up with, and they at the end of it, conceptualize discussion groups, but not just discussion groups in any way. It is through movie nights, to talk shows, monologues, debates, women's and men's zones, and The picture you see was one of the zones that they had at Belleville campus, which was on Valentine's Day, which is a love zone type of discussion. And these are just putting tables up around campus and letting them discuss around one specific topic around a table, which we call table topic discussions. And then also multimedia platforms, including social media, so creating memes and various ways. You always have to keep trending with the youth and do not move away from the youth or what they're not currently doing. And then youth-focused conferences and usually our first-year orientation workshops and community outreaches. This is the multimedia platform. We created a CPT news clip, which I'll show you later, which they tackled the issues of blessers. And they designed their own news and made a mock scene with different students from different campuses using different interdisciplinaries. And then the youth-focused conferences is getting TVET colleges and other universities in the area involved, and we then organize our own conferences, get the funding, and let our peer educators take the lead in the discussions by networking with other institutions, writing articles, presenting, even if it's not the most scientifically based article, presenting it at the end of the day, because you're creating opportunities and a platform for them to engage and to involve the youth. And then some of the conference feedbacks, I just highlight one or two of them, that was such a game change in the way we involve students, leaders, and peer educators to engage on issues affecting their peers in the sector and beyond. And so meaning how valuable it is to students and peer educators that are active change agents to be involved in policy differences and making policy decisions on campus. And that was another quote from our peer educators, Togamo, as well. Right now, I would like to just show you, Melanie asked that I try to finish a little bit with time. We have 2 minutes left to show you the brief clip that we've developed with our multimedia platforms on campus, as well as our film and photography department. So drawing in different disciplines on campus to design a concept which was made and done by our peer educators. So I think that video, and I do not know who the person is, but the video is on the folder. There we go. Sound, please.
My name is Tabo.
And I'm Mary Jane. In today's headlines, we cover the big fight that broke down in the Belleville campus cafeteria and we speak to the side chick of the biggest fight CPUT has ever seen.
Mary Jane, just hold on a bit. Excuse me, we're being interrupted with breaking news from the HIV and AIDS unit. Apparently, there's been a huge outbreak of students having blessers and spicy mamas on all campus. This new phenomenon has taken all CPUT campuses by storm.
Oh my goodness, Tabo. Apparently our students have been engaging in unprotected sex and have been using condoms for everything else but sex. And on top of that, a few of them are getting tested for HIV.
Let's now cross over to our live correspondent from the HIV and AIDS unit, Virginia.
Virginia, are you there?
Yes, I'm here. I'm at the HIV and AIDS unit with one of the staff members, Mr. Nathan Kesier, who is going to tell us more about their findings. Good day, Mr. Kesier. Could you please elaborate on your findings and tell us whether it's true, and also tell us what the HIV and AIDS unit is doing about it?
Good day, Virginia. Yes, this is indeed a very, very common phenomenon. It's actually spreading across all our campuses. This term blessers is actually an old concept for sugar daddies. There's also a new concept called spicy mamas, and they are actually older women taking advantage of our younger guys on campus, which they call pentens. Now, the HIV and AIDS unit takes all of these issues extremely seriously, you know. And you know what we do actually? We're also thinking this is risky sexual behaviors our students are engaging in, and risky sexual behaviors are things like unprotected sex and also engaging in alcohol and drug use. So the HIV and AIDS unit tries their best to tackle all of these issues.
So what kind of services does the HIV and AIDS program offer to students, and what also can students do to avoid getting involved in such risky behaviors?
The HIV and AIDS office actually has a vast array of services we offer to all our students, including HIV testing and counseling from our office in Cape Town, as well as our mobile unit all over different campuses and residences. We have a very good peer education program, which is CPUT students that actually initiate and conceptualize interventions, workshops, and programs. Okay, so that is basically just our Chair has just told us we're out of time, but that is just a basic example of what we have been doing with our peer educators and letting them do the scripting and all the work indeed. So at the end of the day, it is making sure that the youth and our students are part of the change on campus and not having HIV fatigue or information overload, as our presentation has said. Thank you very much.
Thank you very much to the CPUT team. I think quite an interesting innovation in this regard. Ladies and gentlemen, we've run out of time. We did start late. I think we have a moment for one or two questions quickly. This session is continuing at 3:30. We're also having the next session on this track, which is continuing on peer education programs. Are there any burning questions on any of the presenters? Maybe a question on the sugar daddies and spicy mamas? There are mics in the middle corridors if there's somebody who wants to ask a quick question. And please, a quickie.
Okay, good afternoon, guys. I just want to thank all the presenters for nice presentations. My name is Mokem Molojo. I'm from Provincial Department of Health. I'm responsible for key populations. The question is, I want to ask Mr. Moshiwa. I'm not sure whether I'm pronouncing your name right. Yes. He reported that out of 1,300 MSMs from the campus, but only 60 were unable to test for HIV. I just wanted to check with him, maybe were they able to check the reasons as to why only 60 out of 1,300? I know maybe they didn't, with the research, it wasn't included in the research part, but after seeing the results, were they able to say, what is it, why it's only 60 out of 1.3?
Thank you, that's a good question. Any other question? Going once?
Hi. Good afternoon. Thank you for the presentations. My name is Nekuzayo from the Department of Health as well. I just want to pose a question to Ms. Makuwaza with regards to the graph that she showed us, where uptake grew in the two periods, 2014 and 15, and it dropped. But the interesting factor is that the uptake was higher where there was incentives. Now my question is, did you look into the possibility of double counting just because the students were interested in the memory sticks and the like? Thank you.
Mr. Moisha and Mr. Makauza, please. Oh, a late breaker, okay.
I have a short question. I hope you do understand it. My question is, okay, we hear as the youth, and then, it's based on the sugar daddy issues. So now, what is being done, like, how are these older men being educated about such? Because then it does not only involve us about the youth, it also involves them. So what programs are there to educate them? Yeah, that's my question. Thank you.
Okay. Any programs for sugar daddies?
Hello. Thank you for the question. And I think it's valid in terms of potentially there being double counting because there were incentives. I think right from 2014 when we started using incentives, it did come clear that yes, these are youngsters we're dealing with, there is potential for them to double report. So in terms of controlling that, what we then did was then to try and manage the process together with the partners that we were working with, using, for instance, the markers that are normally used during election time, when you vote, you get marked or you get inked to show that you've actually voted and participated. So those are some of the processes that we were using to ensure that we don't then end up with a situation whereby we have students who are actually double dipping in terms of getting incentives. So this data, basically, we then came up with a system to ensure that it doesn't happen. Thank you.
Yeah, that's fine. I'd like to thank the audience member for that question. The issue about the number of people that attended our other interventions versus the issue of the HCT uptake has always been, I think it was part of the reason why we had to have this intervention to begin with. But little did we know is there is going to be an issue of how do we can recruit and mobilize all the MSMs and LGBTI students. Now the issue is, how do we tell that the people that took up the services are MSM or part of the LGBTI community? For instance, I'm glad you're from the Department of Health. In our consent forms, is there a place where an individual can identify their sexual orientation, for instance, which is the only way, how we can tell that this individual is MSM or a part of the LGBTI community. We had an intervention with that regard. We actually modified our consent forms, but then this was done at a later stage. Within the 3 years, this was done at a later stage after we realized that we need to be able to identify them. Yes, indeed, we did that. But then again, it is how the individuals respond to that question. I know that there were, as we are seated here, we all had different methods of getting people to identify as LGBTI individuals, and that hasn't been, scientifically proven to be the case that individuals are indeed going to be able to identify. And the other thing is, amongst the individuals, we still have individuals that are not sure. Remember, we can't out everyone, by asking them, indeed, are you, depending, because now the question is, are we going to judge at the way a person is dressed, and then we imply that they are part of the LGBTI community? So it is also upon them to disclose to us that I do take part in high-risk sex. I do belong to the LGBTI community. So that has been the issue, and hence the discrepancy, or let me not call it the discrepancy there. That's why there's a difference within the number of people that took part in our support groups or other interventions, whereby we could have easily gotten all of this information through a register, and as opposed to people that took up HCT, whereas our consent form wasn't speaking to identifying people's sexual orientation. I hope I answered that well. Thank you.
Thank you very much. The third question was on who addresses the blessers, because we're talking here about the students, about the youth, particularly young women, who in many instances are vulnerable.
I will answer one part of the question. I think what we must maybe keep in mind, the blessers are not only older men. There's blessers at our universities that want to bless girls with a bedroom. They want to bless girls with airtime. They want to bless them as well. So we're creating awareness at our own institutions around the issue of blessers. Because we also know those are men that are going to become much older. They are going to go out from the university. So we want to change behavior at the institution level already, and we address it at our institution. We have our own youth leadership HIV and AIDS conference where we specifically target student leaders, women in leadership, SRC, peer educators, peer helpers, RSAs, House committee members. We're targeting all those, including staff as well. So we really create a lot of awareness around the issue of blessers. We also know, we have to be honest as well, we also know there are female students that actually approach the older men. They actually go and say they want to go and get blessed. So we need to correct that behavior as well and really make them aware of the risks that they expose themselves to. So that is what we do from one angle. At our institution, as I said, we create awareness of blessings because we could have staff that are blessings as well. We don't know. So that is what we're doing. So that is the two parts that I wanted to respond on. I'll leave the rest over to my colleague.
I think Melanie has touched on everything that we need to speak about when we speak about the blesser or spice or spicy mamas or even sugar daddy concept, whatever you want to call it. I think what you did is actually give a solution. Because at the end of the day, yes, we do need to go for the population or the target population of the blessers themselves. But there's nothing in place. And I feel having the Department of Health in the room, that is something that we need to do in our consent forms when we do HCT testing and all of that. What is your high-risk behavior? And are we identifying being the blesser as a high-risk behavior? And if we identify it as a high-risk behavior, we will be able to get the solutions. So maybe we need to change our policies. Maybe we need to change what we have in place to identify this as a high-risk behavior. Because at the moment, the high-risk behaviors are everything else, alcohol and drug abuse and all of those, but it's not identified. So if we change our forms and our structures, and a nurse knows that this is a potential blesser that's sitting in front of me in my consultation, maybe I need to give psychosocial education. But from the education, higher education's perspective, we can only work with the population we have, and those are the university-going students. So hopefully our other sectors can help us getting a solution by putting or curbing this issue and ill within our communities, but is the blesser or the spicy mama or the sugar daddy issue.
Thank you very much. I think we should give our excellent panelists a round of applause. I think there's a lot of lessons learned on your presentations, your interventions. And colleagues, unless we enhance these kinds of programs, we will never turn the tide against HIV. If indeed we want to see the decline in the infection rates in our country, we really need to enhance such programs that we know work and scale them up so that indeed we can see future generations that are AIDS-free. So thank you very much for all your efforts in the wonderful work that you're doing, and all for the best. I would like to invite you to come back in this very hall at 3:30. My colleague Jonathan Brady will be taking up the second installment, where we'll still be learning more about peer education programs. Have a wonderful break, but please be back on time so that we can start early for the next one. Thank you very much. Hello, sorry. Somebody lost a bag with a camera, a cell phone camera, Canon. If please, what type of a bag? Yes, is it the conference bag? Yes, please, if you found a bag that does not belong to you and there's a camera inside, can you please take it to the information center? Thank you.
God. Oh. Okay. Okay, welcome back everyone. Sanbonani bo? Yebo. This is the second half of the session on peer education. I think we've lost a bit of time, but that, I suppose that's normal in these circumstances. Our first designated speaker is not here at the moment. Oh. Here she is. Our first speaker, Mrs. Celeste Sauls, will be coming to present her study on the uptake of adolescent in-facility HIV testing services conducted by peers at public primary healthcare clinics in Thabo Mafutsanyana. Oh, by the way, my name's Jonathan. My name's Jonathan Brady. I'm a master's student at the University of KwaZulu-Natal in Population and Development Studies. I am on course to finish, hopefully this year. And yeah, this is my first conference of this nature and size, and I'm very excited to be here. I hope you guys are as well. Please welcome Celeste. This is one I'm very excited about because I actually reviewed this one myself. I'm very, very excited about this one. Give her a hand.
Good afternoon, everyone. On behalf of my co-authors, good afternoon, everyone. On behalf of my co-authors, I'll be presenting on the uptake of adolescent in-facility HIV testing services conducted at by peers at public health at a primary health care facilities in Thabo Mafutsanyana district, which is in Free State. So adolescence is a very important, and youth is a very important time which many changes happens to individuals, whether it's biologically, physically, whether it's behavioral, but we see significant changes. And as such, that is also a key component or a time in individuals' lives where they start maturing sexually and also explore sexual different practices as they grow. However, adolescence requires challenges which result in them not exercising their right to accessing services. Such of these challenges may be transportation, stigma from the community, transport cost to access facilities. So we don't often see them access health facilities for prevention services that are so freely available. We also found that sexual transmitted infections, including HIV, can have a profound impact on prevention services available to this target group. We know that adolescents make up a quarter of the sexually active population, and globally they make up half of new STI infections, so every year. So although we've seen significant progress that is underway through various programs in different provinces to increase access, coverage, and uptake of HTS by adolescents and young adults, we know that approximately 2,000 women aged between 15 and 24 in South Africa are newly infected every week. In Thabo Mafutsanyana, HIV prevention services are freely available at clinics, at all primary healthcare clinics. In the past, counselors were removed and clinicians, as nurses, they were given the responsibility to test adolescents and young people. However, the uptake of these services for or among adolescents and young people remain low. We therefore wanted to review the uptake of prevention services by adolescents and young people aged 15 to 29 years, provided by peer educators. The peer educators that we placed are around the same age. So that's just a map of Thabo Mafutsanyana, if you're not familiar with it, with the biggest impact or the highest prevalence being in Maluti Apofung, and that's where we placed our peer educators. So we had 5 adolescent peer educators. They were placed in 3 PHC clinics to provide HTS, health talks, prevention services, giving condoms, lubricant to adolescents. They also did some outreach services to let the young people know that they're the ones providing HTS at the clinics and they should come because services are freely available. So we wanted to see whether having a same age person doing your testing, whether it will result in a greater uptake of the services. We used HTS registers at the clinic daily to collate and collect our data. The data in our analysis is stratified in 5-year age bands, and the percentage change in uptake of HTS is reported. So we have adolescents, boys and girls, aged 15 to 19, youth, 20 to 24 years, and adults, 25, young adults, 25 to 29. For our results, over the 2-month period, which was January and February, we had 6 adolescents and young adults that entered the facility. The study population, as I alluded to, was between 15 and 29 years. 72%, as you can see, were female, and males made up 28%. More than 40% were aged between 20 and 24 years. We found we saw or observed an overall percentage change of 34%. So between month 1 and month 2, we had an increase in the uptake of HTS among our adolescents and young people at these facilities. In the highest uptake, as we can see, is among our 15 to 19-year-old boys. They had an 80% increase. Secondly was our 20 to 24-year-old males, so mainly males, has increased to 51%, and we had a 33% increase among females 15 to 19 years. We, however, did see a decrease among the male adults 25 to 29 years. We then, after the 2 months, felt that using peer education or educators, in health facilities may increase our uptake and accessibility of prevention services by adolescents and young people if it is offered by a peer. However, robust referral of young people from other points of the clinic. We know sometimes you only go to the clinic to collect medication. However, we felt that you should be referred from all other service points to participate or be encouraged to participate in prevention services. We also felt that extended working hours, a dedicated room with a nurse trained on adolescent youth-friendly services might also increase the uptake of prevention services. The area, there's 3 or 4 different TVET colleges, and the students can only come after classes, and at that time the clinics are mainly closed. We also felt that if we fast-tracked adolescents, this may also increase the uptake of prevention services for adolescents and young people at these clinics. Thank you. These are my references.
Thank you, Celeste. That's a very relevant topic, I believe, because castigation, stigmatization of youths trying to access health and reproductive services it's a big issue. One that I know a lot of people have worked on and are advocating to change. Thank you. Thank you for that, Celeste. Our next speaker specializes in the field of sexual and reproductive health of youth, social and behavioral sciences. She holds a master's in philosophy and PhD in this area, and probably has a lot of extensive experience and research to share with us. So please welcome Professor Matilda Mokgatle.
see. What happens? Where do I see the slides?
You see it either there or on the TV.
Oh, there. Oh, okay. Thank you. Good afternoon. And I advance with the green one. Okay. Okay. I'm going to talk on motivators for high acceptability of HIV self-testing among TVET college students in Gauteng and Northwest Province. I'm from Sefako Makgatho Health Sciences University, which is the old Medunsa, and Tshwane and Bojanala district, in Gauteng and Northwest Province, our catchment area. That's where we do most of our research, and that's how we got hold of recruited the TVET colleges in that area for our research. HIV self-testing is a new innovative way of testing. Is a home test kit, which most of the time people already purchase at pharmacies, and they can test themselves, either using a saliva sample, swabbing in the oral cavity, or just pricking and putting it on a sample, a specimen plate, and you get your results immediately. So it's an instant testing. It's part of the campaigns that wants to increase people knowing their HIV status. And that's how it was introduced, but had some barriers of saying, because there's no counseling that is involved with it, there can be some harm that can happen to communities. But statistics shows the opposite. Qualitative studies tend to come up with people contemplating suicide, but with time, with increasing availability of treatment and more interventions, HIV self-testing has got hope to, and is being taken up in facilities. This is a formative evaluation that we are doing because HIV self-testing is a new intervention. So we thought we should first start and see how the community, the society will be receptive towards it. And we just aimed, our study aimed to just investigate how acceptable is HIV self-testing among TVET colleges. And what I'm presenting now from the formative evaluation, we just did a cross-sectional survey of acceptability of HIV self-testing in colleges. We had 13 colleges in Tshwane area and 3 TVET colleges in Bojanala district in Northwest Province. And the study was ethically approved, and we recruited a sample of 3,662 college students. And we, to reduce the bias of our sample, we just did a cluster sampling so that we can include all the N1 to N6 level students, different qualifications of students. And we just simply approached facilitators. The colleges allowed us to sample facilitators and request facilitators to allow us to access the students after they have given a class. And we administered a 20-minute survey on assessing the acceptability of HIV self-testing among volunteering students in the colleges. So I'm just going to give you a snapshot of the profile of the student that participated in the study. We had, my eyesight is so poor. 56 students were female. I don't see. And most of the age group, I'll just see what I remember because my eyesight is killing me. The majority of the students were within between 20 years and 24 years, close to 70% of the students, because these are most of the post-matric institutions, higher education institutions, and that was an expectation, but we had more, the population of above 25 to 34 that were doing N4 to N6, and others were due to repeating, and others were being deployed by their industries where they're working to come and continue with their studies. And 81% of them were in romantic relationships, and we found that 80% self-reported that they were sexually active. I don't know if I see right. We asked about the number of sexual partners, and we found that 66% reported to have one sexual partner, and close to up to 20% said they had two partners, and others had more than two partners. That's part of risky sexual behaviors that we could see. But just thinking that we did a formative assessment of implementation of HIV counseling and testing implementation in schools. In high schools, the statistics were reversed. We found that the younger group, because they are still experimenting and all that, those that have more than one sexual partner were close to 60%. So here we see, people starting to define themselves, being steady with their boyfriends and looking forward to getting married. And the statistics were, interestingly reversed when you got to that. And I think it's the Maslalisane project that we have in, you become more steady in FET project. But like in this morning when we were reporting behaviors on campus and risky behaviors. Okay, the condom use, 66% reported, at least less than 70% reported to be using condoms. And what the interesting statistics that we have ever tested for HIV, which is 72%. 72% of the college students said they ever had tested in their lifetime for HIV. And we still thought it's still less because HIV, knowing your status is very important. So the 28 that hasn't tested is a concern, and we have to work towards getting everybody tested, and maybe HIV self-testing can be filling the gap of uptake of HIV counseling and testing. And we just asked a question because this is just sampling a few questions that we asked of knowing your partner's HIV status, and we found that 60% said they knew their partner's HIV status because we were asking various sexual behavior and condom use questions. And on the issue of acceptability of HIV counseling and testing, we use this as an outcome on bivariate analysis, and on our statistics we found a whole lot of variables which were significant. You see the very last column, p-value, the zero shows a statistical significance of willing to use HIV test, okay, willing to buy the self-test kits, which, the price range, from 11 rand to 40 rand. We see that, most students said they would be willing to buy it if it's not available for free. And, using, giving in report. After you have tested, you can go and confirm. There's a protocol for HIV testing. So most students said they could go and confirm results, and they could also go and submit their results for statistical purposes to see the achievement of the HCT campaign that is part of a national program. And so those were statistically significant. But when we went to logistic regression, we found that on unadjusted odds ratio, we had a statistic on HIV testing with a partner showing those who wanted to test with their partner and use as HIV self-test kit with a partner were 3 times more likely to get the acceptability of HIV self-testing compared to other counterparts. But on adjusted odds ratio, we only ever tested for HIV was the one factor that motivated people to uptake the new innovative way of HIV self-testing. And that is the case in most cases. Even in high schools when we did HIV implementation, HIV counseling and testing implementation, people who ever tested, and statistically in all literature that I have seen, are more inclined to use new innovative way of HIV testing than those that have never tested before. And it means this quarter of a population that don't know their status or not have tested anymore should be encouraged to test, because it makes them more prone to practicing and uptaking HIV testing than other, and then we can achieve our Knowing Our Status campaign in the country. And that is part, of my conclusion. And as the youth conference is saying that you have already claimed by willing to buy self-test and already using it, and we just need to have supportive programs that will enable you to know your status at a convenient, private, and easy space that doesn't take time from your education. Thank you.
Thank you, Dr. Mokhatle. Just a bit of a late announcement. Those of you who are from Mangosuthu University of Technology, the last bus is probably leaving right about now, just to let any of you know. The main theme I'm starting to pick up with some of these early presentations is the issue of discretion. It's quite important. I think something as important as self-testing is pretty crucial when it comes to exercising discretion and control over the knowledge of your status. Even with having your peers work with you in a clinical setting is also quite a new, it's not novel, but it's something that should be more implemented, and it's good to see programs identifying these kinds of things. So moving along, our next speaker has 17 years in the field of professional nursing. She is currently an HIV/AIDS program coordinator at UFS, the University of the Free State. She has a BK in specializing in nursing education and community health sciences. So please welcome Lintle Mali. Oh gosh. Lintle Malimabe.
The green is forward versus back?
The green is to move forward.
Okay. Thank you.
You can read off the TV as well.
Okay, thank you. Good afternoon, everybody. Afternoon, everybody. How do you do? I'm good. Okay. Let me pronounce my name correctly. My name is Dintle Madimabi. I come from the University of the Free State, KwaZulu campus, and I have been in the field of HIV for 17 years, not in the nursing field, just HIV. Okay, I'm going to present to you how we go about the program of HIV and AIDS among the youth in the University of Free State, where I am situated or working. Oh, sorry. Technology, guys. The theme, everybody is quite aware about the theme of the conference, and then I'm going to discuss with you the different approaches that we employ at UFS KwaZulu campus. We do what you call PJ parties, pyjama parties, and I always encounter a problem whenever management has got to approve. They will be saying to me, now we are going to do a party, a pyjama party, and there's going to be alcohol. I said, no, guys, let me explain to you how it does work. A PJ party is nothing but a gathering of young people whereby we come later in the evening and spend the whole night discussing issues that really concern young women and guys at the university level. So it's nothing about alcohol, it's just about whereby people are being empowered, and then What basically happens, students are given a chance to write their questions or whatever they want to discuss on that particular evening on an anonymous basis. You don't attach your name to the paper that you're going to write. And then after everybody's done with writing or whatever, we just pull one question at a time, just like a rifle, and then we start discussing, and you normally set aside a certain time, then we pass to the next. So it's really something that young people are really fond of, especially guys, and I don't know why, but they really like it, because they would even call me, hey, Mama Dimabe, last year it didn't happen. What was that? And I said, fees were falling last year, so that is why many things didn't happen. Another strategy that we employ is dialogues with students. The difference between a PJ party and dialogues is that in this particular one, we are the ones who usually give the students topics, whereas in a PJ party, it is actually driven by the students. What is it that they want to be? They want it to be discussed in that particular evening. So dialogues normally, maybe we start at 18 or 19 hours, and by 23 hours, 11 p.m. we are done. So it's not an all-night event like a PJ party. Another strategy that is working for us is we call it condom bash. So the minute the word bash is mentioned, again, that is where trouble comes. And I have to explain again, you know what? Since young people are very tired, they are, they don't want anything to do with AIDS. Oh, AIDS information session, no. So we had to sit down and come up with these nice names that are going to attract young people. They know exactly what is going to happen, but the mere fact that you decided to call it a bash, they will be coming in large numbers. And then it's nothing but to promote usage of condoms. Because really, as much as we would like our young people not to engage in any sexual activity, the fact of the matter is they are doing it. So we try to make it a point that if you think you are old enough and responsible enough, the simple thing that you can do, please do it responsibly. Protect yourself from unnecessary STIs, HIV, as well as unplanned pregnancies. And then another strategy that we employ, we honor all the events that appear according to the Department of Health calendar. For an example, every year on the 1st of December, we have World AIDS Day commemoration. In the 2nd or 3rd Sunday of May, we have what we call candlelight, and then we have the STI and condom week. So we honor those things by organizing the events together with the peer educators, student peer educators, because they are the right people to pass on the message to the other fellow students as they experience the very same problems that other students are going through. So anything coming from my mouth, you can just imagine, as young as I am, and I'm telling 18, 19-year-olds to abstain, they'll be saying, ooh, where does she come from? Mama Dimabe, what is wrong with her? But if it is coming from a youngster, just like them, then it has some weight. So maybe they can say, let me consider it. If my Bongwa can do it, maybe I can also do it. Then we also collaborate with other structures within the. They usually invite us. They'll be saying, we'll be having a gathering of 2 hours. Can you come with your transformers or peer educators? Because that is what we call our peer educators in KwaZulu campus. We call them transformers because the main aim is to transform that campus, transform the lives of other young people so that we can see them graduate alive. So we also do a lot of community outreach projects. You find that in September there is what we call School AIDS Month. It used to be a week, but now it is the entire month of September, whereby it is dedicated towards teaching learners in high schools and primary schools about the issues of HIV and AIDS. We normally visit the senior secondary schools, and then normally the names that they give us, the names of the schools to be visited, they check the number of teenage pregnancies that happen there, because whenever there's a high number of teenagers that are falling pregnant, it's obvious that they are doing it without protection. And sometimes, okay, again, as far as the community outreach programs are concerned, during February, the STI in Condom Week, we normally plan a fun walk or a fun run, whereby even the members of the nearby community are welcome to come and join us. And then immediately after the walk, there are some messages that are passed regarding HIV and AIDS, not forgetting the condom demonstration, because people will be telling you that they know how to utilize a condom, but only to find that if you can give him or her a condom and say, here's a condom, can you show me? You always come saying the condom best, but how do you use it? You find that they really don't know how to use a condom. So that is what happens. So we also do the female condoms as well, demonstration. Yeah, so these are some of the pictures. This is during the School AIDS Month. I think it was last year, whereby we were visiting those designated schools. Yes, and then we were talking about HIV, teaching them about HIV and AIDS. So what doesn't work, we've realized that if you force people to come and listen to you, people should come to your information sessions because they want to come, not because they've been told to. Number two, if you are talking to a large crowd of people, you'd find that it's not easy because they become unmanageable. A large crowd is usually associated with some challenges. And then sometimes if the students will just ask you, are there food, are there refreshments? If we have nothing, any form of incentive that we have for the students, normally you find that they don't attend your events. So thank you very much. That is all that I can say about what we do.
Thank you for that, Ms. Marimabe. Our next speaker, Mr. Thandi Mzizi, is going to present his presentation on evaluating the effectiveness of peer education programs at Rhodes University, what works and what doesn't. The trend obviously is moving more towards the organization of youths amongst themselves and how they can address the pandemic of HIV, AIDS as a group rather than as individuals, which is also important. So please welcome Mr. Mzizi.
How do you move this thing down?
Just control forward, that's backward. I see it printed at the TV.
Okay. Thank you. Good day, everybody. My name is Thandi Mzizi. I'm an institutional awareness specialist at Rhodes University. I'm here to present or sort of evaluating the effectiveness of peer education program at Rhodes University, what works and what doesn't. Doesn't work. How do you? The green one. Okay. Yeah. Well, I decided while I'm here in the podium not to talk much about the introduction, but where the peer education come from. But rather, let me start by just talking about the background of peer education program at Rhodes University. Now, the background of my data collection, I can't really see over there, but let me just talk. It actually comes from the report of the higher education HIV/AIDS programs, where around 2008, 2009, where the prevalence of HIV and AIDS at Rhodes University was around 1.5%, where the students' prevalence was around 0.5%, and academic staff was actually 0. However, staff members, the administrative staff was around 6.7%, but the service staff was around 12.9%. Now, HE-AIDS report showed that Rhodes University is one of those universities with a very low or HIV/AIDS among academics and students. Now, the recommendation from HEAIDS was that the news that Rhodes University has one of the lowest HIV prevalence rates may lead to the Rhodes students and academics losing their HIV prevention motivations. And we had a student society called SHAC. SHAC is a student HIV/AIDS resistance campaign, which worked very, very well to try and mitigate the spread of HIV and AIDS among the students of Rhodes University. But the recommendation was that we need to establish a peer education program among students and staff members. Now, the first thing that we did, we recruited students and selected them and trained them. But since 2015, we changed our strategy. We let the students train their own students. We've got senior students, those who we have got two fourth-year pharmacy students, and one master's student and one PhD student who tend to help us to train their own students on HIV/AIDS. That's where you've seen students training each other. Yeah. Now, we have adopted a model based on the work of Professor David Dickinson from Rhodes University, whereby we ask students to perform different roles. This one is the sex talkers. At Rhodes University, students manage to talk openly about HIV and AIDS. They have programs or some programs like Pillow Talks, where they speak about contraceptions, sex and sexuality, MSS and LGBTI, delay in sexual debates. I recall one day I went to their program whereby they were talking about, even some of them, they said we use DIY. In other words, some of students will say, I'm not involved in sexual intercourse, but I'm using DIY. If I may ask the audience, what do you think DIY means? Yeah, is do it yourself. It was actually the first time hearing that. So these are the things that they discuss as sex talkers. We also have condom kings and condom queens. You know what they did? They, instead of asking, donation from the Department of Health or from any other NGOs, what they did, they approached the building maintenance of Rhodes University so that they can construct very cheap condom dispensers using wood. And the students themselves will collaborate with other students so that these condom dispensers should be mounted either in the toilets, the corridors, or the restrooms. Now, the role of the condom kings and condom queens is to demonstrate how to use the condoms correctly and consistently, and also how to distribute them. The other role that we're doing is the stigma busters. If you look at the picture, you'll see a lady. This lady is written there, I am living with HIV. Now, many people, when this campaign was done, many people, they tend to think that that person is HIV positive. But they were just, putting their faces there In other words, they are not actually saying, I am HIV positive, but they are actually saying, we are living with HIV. In other words, that person is not necessarily is HIV positive. But what are they trying to say? Maybe the person that is sitting next to you is HIV positive. Maybe themselves, they are HIV positive. But what do you do about it? All right. And then the others, one of the other role of the peer educators is the influencers. They tend to engage with other students and influence them to change their behaviors. In other words, in how to use the condom correctly, and also how to try and reduce the multiple partners, alcohol and drug abuse, yeah, my time is up. Okay, and then how to keep, how to keep the peer educators motivated. One of the things that they've done, or what we have done, is to try and motivate them, because all our peer educators are there on a voluntary basis. We visited the Constitutional Court, whereby we wanted to meet the Justice Cameroon. The reason why we wanted to meet with Justice Cameroon is because he lived openly with HIV, and he pronounced it that he is also a gay. We also visited the Union Building, Wits University, University of Pretoria. Now, the results. We look at the, in February, we want to look at the results of, in February 2015, how many students who were treated for sexually transmitted infections. And we found that there were 8. We got those results from our healthcare center. And then how many in the same month in 2015 who used PPC, that is, okay, 30 seconds. That is morning after pill, there were 8, and pregnancies, there were 10. And then in February 2016, STIs were 6, PPC was 0, pregnancy was 9. In February 2017, STIs were 6, PPC was 0, pregnancy was only 1. All right. And then what we found out, the peer education intervention was significantly associated with the increase of condom distribution or use, and there was a reduce in a number of students that use morning after pill and unplanned pregnancies. However, peer education program has no significant effect on STI infection. Okay. We want to thank HEAIDS, Prof. Dickinson, RU, UCT, CPU, UOS, SU, UP, VETS, and Justice Cameroon. Thank you.
Thank you, Mr. Mzizi. There was one aspect of your presentation that I found very interesting, was the control test of putting a person's face in front of that caption, living with HIV. It's like when someone lives in a household where a loved one gets infected with cancer, it's not just affecting that one person, it's affecting the whole house. I think we need to start looking at HIV in a very similar way, so that we can develop more empathy and look at how we can help the next person, because there could be people in this room anywhere you go that need support and just need someone to reach out. The next speaker is Mr. Vinoba Krishna. His topic would be peer dialogues, getting the youth talking. So please welcome Mr. Krishna.
Good afternoon, ladies and gentlemen. So I have a brief discussion this afternoon, and it's essentially talking around peer dialogues. And it's talking about literally our small little intervention that we had at Wits University. And I just want to share some of those experiences with you. I know it's been a long day, so thank you for bearing with us as well. So essentially, just to start off, we have to ask the question about why youth dialogues. And one of the things that we need to understand is that we come from a fairly recent history of institutionalized social injustices or injustice. And many of this is still quite visible in our society. When we look back at the TRC, for some of us that kind of still remember the TRC, it shows us an example of how dialogue can work. Even though it was short-lived, it certainly is still an example of something that we can build on. We look at stats essays, statistics on youth. They make up 1/3 of the country, more than 1/3. And therefore, it's important to get this sector of society talking. And that also, when we look at the national youth policy, they see that young people still face many issues relating to mental health, poverty, family disruptions, violent crimes, HIV and AIDS, and substance abuse. So these are very real, researched issues that are still a concern to this sector of the community. Okay. If you look at the daily news, if you look at whatever's on the social media, you'll find tons of issues relating to social injustice, particularly to the youth of our country. And so there definitely is a need for dialogue. And part of the need for dialogue is because we have institutions where there are many intersections between diverse communities. So we cannot avoid interaction with homosexual or LGBTI kind of communities, or communities from different race, class, gender, those social or class stratifications, etc. So those intersections necessitate the fact that we need to be talking about it. Friedman and Combs, they talk about prejudicial worldviews. Prejudicial worldviews will continue to persist if there is no dialogue. And therefore, it's important for us to encourage dialogue. When we encourage dialogue, we reflect on our personal stories, we reflect on our personal experiences, and that reflection helps to build bigger perspectives, helps to build change. Okay, so the context that I want to share with you just briefly is about the Wits dialogues that we hosted. So we hosted, or let me just put this in perspective firstly. So there are tons of dialogues taking place, even on our universities, as I'm sure on other campuses as well, other universities across the countries, other higher education institutions. So what we have is sometimes roundtable discussions on transformation, discussions within our residents' life structures, gender discussions on incidences of rape, of sexual harassment, of gender-based violence, etc. So all of these dialogues happen all the time. But one of the big issues is that many of them happen independently from each other. Not only do they happen independently, there isn't a cohesive, kind of connected way of having dialogue. And that is the big issue. In terms of our peer educator dialogues, I want to share with you the experience of having a series of three dialogues that were hosted towards the end of 2015 and through the course of 2016. And approximately 50-odd students were involved in these. And some of the themes that were covered were intimate partner violence, substance abuse and gender violence, gender-based violence, and then also sexual health. Data was collected over this period. Doesn't look like a big number, but certainly the experience was enriching enough for us to kind of evaluate and look at why dialogue is important. Some of the outcomes of that, firstly, in terms of the facilitator, what we noted from, again, all the data that was collected from students that participated was that having a facilitator who appeared relaxed, open-minded, and in control of the conversation, who had a neutral stance, allowed for individuals to participate without feeling threatened, especially when it came to issues that were quite laden, quite heavy, quite emotive. Students felt that they could participate provided that the facilitator was able to contain those sessions. Secondly, dialogue. most students felt that the space was extremely useful. They engaged with this space. They thought it was quite a useful experience throughout the series, and that they also preferred, and that they would prefer to be involved in future dialogues, but there was huge division as to how could they make time available specifically because of the academic program, a busy academic program. And I think that is always a challenge at higher education institutions, is how do we get youth talking within a very tight and very structured academic program. We asked the question, is there a need to create structured platforms for dialogue? So having very controlled groups or very kind of, again, platforms, very controlled platforms. Most of them agreed that there definitely is a need for structured platforms for dialogue. What were the benefits of the dialogues? When we posed that question to the students, they said it created a safer space to talk about issues around gender, around sexual habits, around condom use, around race, around religion. It just created safer space to actually engage with those subjects which they would ordinarily sometimes just avoid in average casual conversations. It created a space of understanding where people could understand each other and each other's views. They could challenge stereotypes openly and in a manner that was respectful and mindful of each other. It created broader perspective. It allowed for the expression of emotion and that they could learn from each other. Those were actual words that were taken out of that group, so actual kind of statements. What were the benefits, we asked, of dialogue versus social media? We know tons. I mean, the kind of present generation is mostly online. You find people burying their faces in cell phones, on a laptop rather than having face-to-face conversations. And so we asked, what is the benefit of having these face-to-face dialogues as opposed to having online kind of dialogues? And what they suggested was that it allowed for better exchange of ideas, the clarity of ideas. It was easier to share and understand the emotions behind the content. You got to know the person that you were having a conversation with, and it helped also in the breaking down of stereotypes. And then they also added that it avoids the silly stuff, and so conversations that got detracted and missed the point. So these were the outcomes of having, or the benefits of having face-to-face kind of discussions. And then we asked what other social themes would young people be into, social justice themes that young people would be interested in. And again, it's the similar things that we kind of know of, that many researchers point to, but it's the question of whether or not we're having those conversations around sexual health, around relationships, around parent-child relationships, around the morality kind of conflicts that young people have, around mental health wellness. And so the evaluation. So the evaluation of these interventions, of whatever happened, is that if you put young people in a room, dialogue will happen. That is normal. That is an absolute given. Dialogue will happen. But it is whether or not we can create a structured dialogue happening. And that's the important thing. So the facilitators created the space for conversations, and having facilitators and good facilitators is important. Thirdly, that students felt engaging with fellow students in such a structured way was also useful, rather than the casual conversations, and that there was a definite need and a desire for greater conversation to be had around these issues. And then lastly, the recommendations. Students need to be talking face-to-face, so facilitated conversations as opposed to casual conversations need to happen. That's important. And in terms of peer dialogue and in terms of breaking stereotypes, that's necessary. Structured platforms need to be created. It remains a challenge, but I think within higher education institutions that needs to happen. We need to create space for dialogue. And then there is a need for more cohesive intersecting of conversations thematically. Lots of systems operate on campuses, independently from each other in silos, and I think working together is quite important. And that there is a need for conversation and themes specifically as those expressed by young people. So it mustn't be a top-down kind of approach. And that's the end of my my conversation with you this afternoon. I just want to say thank you, and I just want to acknowledge the individuals that are there this afternoon. Thank you very much.
Thank you, Krishna. I think it's important to maintain that we have conversations outside and after we meet in these rooms, because I, for one, have been to many of these sorts of things. And yeah, sometimes we miss points that people want to bring up. I can bring an example. I was at the WITS Center for Diversity, invited as a student leader to go up last year with a friend. And most of the SRCs across all campuses were there. And we discussed, the issue for discussion was transformation. And only once, this is 3 to 4 weeks before Fees Must Fall broke out, only once the issue of fees was brought up in an entire week or an entire 3 days of discussion. So it's important that we keep on talking and we keep on trying to understand each other. Universities, of course, are an important platform because the socio-economic spread is diverse. Universities are a melting pot of various aspects. We know that. That's why we have institutions like higher education aids. But enough of my rambling. Our last and final speaker will be Mr. Leon Roots. He's presenting on using social dialogues to address gender, sexual, and social diversity among students. So yeah, it is an extension of what I've just mentioned. Please welcome Mr. Leon Roots.
Well, the good thing is if you're last, you can just say Amen. Because so much has been said and I don't need to repeat because you're going to see a lot of things overlap what we have discussed. The background is the profile of UNISA student has dramatically changed over the last 5 years. We have 394,000 students at UNISA. So that gives you an idea that it's one of the biggest universities in Africa, but even in the world. These students come from mostly South Africa, but also any part of the world that so we had to come into an innovative space of how to engage with students. An average of 15,000 students pass our offices every month, and they are mostly between 20 to 35. So the profile is also changing from a predominantly older population who are working to a much more younger, unemployed group of students. So we decided that we want to actually start the process of facilitating social dialogues, and then in the process we'd like to actually start developing a model, but also a kind of a manual in that process. So this is just to share with you how we're busy recording the process to at the end to hopefully bring forth a kind of manual. So it's based on a project that we work across 3 sectors. We have access to the private sector peer educators, we have access to students, and we have also NGOs, community-based organizations, and faith-based organizations working with us. And in this space, we create then social dialogues with students and these other partners. So you can see at the end of the day, it allows us to actually look at social diversity issues from different sectors, not only from a higher education sector, but also from the private sector as well as the community. And that really helps us to really go deep into the issues beyond the universities. The project is there to facilitate the advocacy of human rights for diversity, gender, social and sexual diversity at the end. That our students get exposed to not only the university, but to also other sectors. And there you can see, I've done one, need to repeat that. So a social dialogue is really a process. And it must be well planned and well structured. Otherwise, it can go horribly wrong also. So it's a process of negotiations, consultations, discussions, as well as information sharing that brings people to a common understanding, not only about the issue, but also finding solutions to address the issues that comes in. And not every social dialogue is actually about a problem. Sometimes there's a positive discussion, but we can also facilitate through social dialogues about wellness and well-being and things like that. So we are heavily using the definition from the ILO that talks about the three processes in a dialogue, that there should be a level of negotiation. We have to negotiate the diversity, but we cannot do it without consulting from different points of view with each other. And in that process, we exchange information, lived experiences, and processes with each other. And in that comes the commonality in creating this understanding of what is this all about. So you can just see this is the processes that often happen. But a dialogue, for me personally, is really a rich process where people, through a process of conversation with each other, and not a formal way of structuring a conversation, but really like sitting around a tea or coffee and just discuss the issues of today, make it real, and find then together each other from different point of views to find solutions that face us in every day. The key elements is that there must be a central question that comes within a dialogue. There must be diversity in the group. There must be processes that at the end of the day we need to find the common voice. Because although we may disagree to agree, there is a common voice that comes out. Then it is a democratic process. It should be facilitated from that angle to promote equality, mutual respect, and openness. It should be based on trust and safety. We should be in a space when we go into dialogues to really trust each other and to really understand the issue of feeling safe and to be free to talk. The stages that the group normally goes through when they go through a dialogue is the whole thing that they form some kind of identity with themselves, even in the diverse group. Then they sort out the diversity through the differences that they share. But slowly, surely, they get to that common voice or that common understanding by creating some platform to say, how do we move from here? And then at the end of the day, it brings it to a level and say, okay, out of this is how we can move forward. And there are some of the skills of a good facilitator, which some of my colleagues have shared. It's very important that the person must be confident, must be open-minded, must be empathetic as well as sympathetic. It must be a person who can deal with arbitrary and mediation processes, but also to deal with conflict resolutions. So it's very important that these processes must come into place when we do social dialogues. There must be a set of information set that builds the foundation. There must be a facilitation of consultation, and how do we negotiate the solution through the common understanding. And this is just the level of intensity. The more the information is available, the more the consultation will take place, and the more the negotiation will take place. If you turn it around, the less information, the more you struggle, and you don't get your dialogue to move. So there's kinds of social dialogues. It's about life stories that people share. It's about, we have also used where people rewrite a drama group, like people act out a gender-based violence situation, and then we ask the audience to rewrite the whole drama in that process. We have done also interactive gaming, role play, policy. We have interrogate policy and do a kind of SWOT analysis. We do also social intersectionality, where we ask people to draw pictures of like how do they see themselves as a gender today versus a gender in the future. And how does the gender in the future will look like that we may call in the future gender neutral or more gender sensitive. Then we have also community dialogues where we go in spaces where we engage with the communities, with community leaders as well as NGOs. And we do also workplace dialogues where we work in the workplaces around issues of social, sexual and gender diversity. And then we also use it through a process of, at the end of the day, take it to a process that we can do talk shows or we do mock court cases. You can see there's one that we had in Rustenburg, where we had community people, we had workplace people, and we had students, and we talked about sexual diversity. We decided not to specifically talk about LBTI, but to talk about LBTI within the understanding of sexual diversity. You can see also the benefits that was shared by my previous colleagues, so I'm not going to go through that a lot. But I think at the end of the day, the lessons learned that we got so far. We have done 16 social dialogues in 9 provinces that includes community and workplace dialogues. We have exposed students to possible job opportunities through this process even. We have reached 275 students through this process, and 52 academics have participated with us. And then nearly 122 workplace educators participate and 35 NGOs. So lessons learned at the end is about it must be peer-led. We must position our youth in these processes so that they can really take ownership at the end of where do we go from here in solution finding. We must also find a bit of similarity even within the diversity of the group. You need a very well-trained facilitator, and you must make sure it's a safe and a trustworthy environment. We need to talk about confidentiality in such a dialogue. And at the end of the day, there should be a debriefing process to help people to leave that space in a recovered way, rather than often in a very distorted way. So that is why your facilitator is very critical in this process. This is how we report. We look at what were the differences and the commonalities. Then we find what are the critical needs and what is the proposed solution. And this is how we, at the end of the day, bring it into a document that then is used for action planning afterwards. Thank you.
Thank you, Mr. Roots. There were some aspects I found, again, very expandable in your presentation to the larger structure of South African society. Words that, like negotiations and consultations as definitions of dialogue, I'm sure are not just applicable to gender and sexuality, they are applicable to socio-economic divides. We know that terms like radical economic transformation inserted into the public lexicon have re-energized, the discussion around transformation and stuff, even though it's discovered now that firms like Bell Pottinger have just manufactured them generically. They're still relevant. So I'm going to open the floor to questions. I hope some of you were still attentive enough to grasp and to absorb some stuff. I know I'm still awake because these lights have just been shining on my face the entire duration of this session. I do hope that some of you have some interesting questions that will reinvigorate the discussion. So as you can see, on either side, to the left and to the right of the central arrangement of chairs, there are microphones that you can use. I have one hand up in the front. Second hand can be the young lady in the blue jumper. And her friend sitting next to her, of course.
Thank you. Good afternoon, everybody.
Afternoon.
Thank you very much for the wonderful presentations that you have shared with us. They are very, very interesting and informative. I have a question from me or Ausdintle from KwaZulu-Natal. My question is, or must I maybe mention who am I?
Please do.
Okay. My name is Mavis Mpanje from University of Johannesburg at the Wellness Unit for staff members. My question, Do you have programs for staff members?
Okay, when I joined the university in 2009, we still had what you call peer educators, staff peer educators, but now it was phased out, so we are now working more with the student peer educators. I don't know if I've answered your question.
No, you have answered me. It's just that your programs are very interesting, but as a staff member and in our unit dealing with staff members, we ask ourselves whether do we have programs. I think there is a necessity for that, but maybe we wanted to find out if you have that, and then can we share what you have and compare with what we are doing in terms of benchmarking. But thank you very much for the answer.
Thank you, ma'am.
Good day, everybody. My name is Tsogofatso Modise. I'm from the University of South Africa. I'd like to thank all the speakers for the interesting presentations that they have shared with us. My question is directed to Professor Mokhatle. You had spoken about over-the-counter testing. I wanted to firstly understand, is the testing kit a rapid kit? And also, if so, because we attended a conference hosted by the HE-AIDS in Pretoria, Fair City, and they had explained to us that if you take your medication and you're HIV positive, you take your medication, thus your viral load becomes undetectable. And when you use this rapid test, I think there might be a danger in those that might not understand. If the test that we are getting over the counter is a rapid test, I could prick myself with my partner and then I may be HIV positive. But because it's a rapid test, the results are going to become HIV, the results therefore are HIV negative. And then I might infect my partner in so doing. So could you please explain the shortcomings? Because it seemed as if you were promoting, pushing this rapid test over-the-counter stuff, but you didn't explain the risks in greater details to those that don't know what might, okay. Thank you very much.
HIV self-testing, the intention is to remember with the HCT campaign that wants to, know your status campaign. We want to encourage people who, the new testers, so that we can increase uptake of HIV testing. And we know that the rapid test, like you're talking about it in a context of an intimate relationship, maybe testing with a partner, and the way I understood you testing with a partner when you know that you are HIV positive and you are on ARV, and you know that your CD4, you cannot detect the viral load. That's what you were asking, isn't that? Did I get you?
That's what I'm asking in essence. And those that might not, because we cannot assume that people know, whether university or in the township, we cannot assume that people know that rapid testing is the rapid testing, So I wanted you to explain.
Okay.
So how do we fill out that gap? Yeah.
Okay, I get you.
And also the shortcomings of this rapid testing, other shortcomings that you came across.
Okay, the context of HIV self-testing is based on the fact that once you are keen to test, is usually most people who uptake it is people who never tested, or who want a repeat test because they felt that they've undergone a risky behavior. But the protocol is you have to confirm your results. Once you pick up that you are HIV positive, even or negative, you are free to definitely go to a facility to get HIV counseling and testing and uptake test at the primary healthcare facility. That is what the protocol is. And I think that the leaflets inside, it's just that due to the language barrier, it's only, the bulk of the packages are in English. So for now, that is what the private sector, mainly through the pharmacies, is offering, because the government sector has not yet adopted it to a larger extent. But in the pharmacies there, but most of our young people, our school-going and out-of-school youth, read English well, and it's easy for them to use the HIV self-testing. Then that's what we have picked up, and we haven't had complications of them misinterpreting their results, because once you test and you are not happy about your results, you definitely have access to a health facility to confirm the results. That's how the shortcomings of the rapid test are being prevented.
Okay, good afternoon, everyone. We appreciate all the presentations that we received today, and thank you very much. My name is Piran Dlovu. I'm also from UNISA, and I too have a question for Professor Mateola, because, with the self-test kit, it's still questionable whether as a nation we're ready for such at the point that we're at right now. Okay, I'm sorry. With the little knowledge that I have, it was said that after you are diagnosed as HIV positive, then you should start treatment immediately. Can you confirm that? Okay, if that is true, then how is that going to work with the self-test kit of HIV? Because people are still stereotypical about going for treatments in the public health facilities, because we know that ARVs are not being sold. So how is that going to work? Because the aim is not just to get people to know only their status, but to also use treatment after that. So what if one is reluctant to go and actually start their treatment, and they're reluctant to do so? Because I think that is one of the shortcomings about having a self-test kit, HIV. Thank you.
The bits that I got from your question, you say after testing, remember that you have to go to a health facility for confirmation so that you can get counseling, pre-test and post-test counseling, and then be, absorbed into the normal primary health care, free access to ARV, services. So the target for HIV self-testing is actually just to motivate people who are not keen. Remember, the literature tends to say people who want to test usually want to test, and whether there's pre-test counseling or not, when you are determined to test, you will definitely go in and uptake a test. So self-testing is appealing to those people that are usually intimidated by counseling or are not satisfied by counseling, but they want to know their status privately. But those people, once they know their status, they know that I need a healthcare, access to healthcare, and they'll definitely go formally to an institution and get services from healthcare providers for HIV treatment, care, and support, and or HIV prevention programs that are available from the service providers within the counseling services. If I understood your question well.
Next question in the back.
Yes. Afternoon. Thank you for this opportunity. My name is Tinotenda Mpezeni, and I'm a student at UKZN and also a peer educator. My question is to the gentleman who spoke last about the dialogues. So what I've noticed is that, from my experience, is that I attend many different dialogues where people speak, and you see that it's a good opportunity to understand what the thoughts behind the topic that you're studying. But also, one thing I've also noticed is that usually after these dialogues, not much is done in terms of change. So my question to the gentleman is that, how do you measure a successful dialogue, and what steps can you do to sort of measure that or record the successes of your dialogue? Yeah.
I think you have got a valid point there, that many dialogues end up with just a conversation and nothing happen afterwards. We have, in that process, decided that we want to structure the dialogue a bit, that it does end up with an action. And that action then goes into our planning processes in the broader project. And we track all those recommendations and all those kind of way forward actions, and we try to implement as much as possible. And some of them we even engage with other stakeholders which we feel are important to actually take on the action, and then we monitor that implementation of that action. So we try to always direct the dialogue to a specific action that is just not just a talk shop, that there is action, but we also put the ownership back on the students and the participants on taking that action themselves as a way forward, that it's not really just shifting it to other people, but also by themselves. They have to take the ownership to make it work. How do we measure it? We at this stage still in the early phases of implementation. Maybe give me 2 years' time, I'll come back and tell you. But I think the major thing of how to measure it is to really ensure successful implementation and to make sure at the end of the day it does bring the required change.
Can I just add to that as well? So also not to take away from the fact that dialogue in itself is a way of just broadening perspective and changing stereotypes and changing attitudes. And I think that's also the bigger picture in terms of engaging, especially around social justice issues. Thank you.
Okay, for purposes of time control, I'm going to accept 2 more questions maximum.
I'm here. Thank you. My name is Spatalala Mahlangu. I'm an activator at Activating in Mpumalanga. My questions are based on impact. First, from the stats given by Mrs. Souls, sorry if I'm pronouncing wrong, that 2,000 women are infected with HIV every week. And in Thabo Mufutsa Nyana, they have 5 adolescent peer educators placed in 3 clinics. My question is, how are you intending to also encourage those who do not visit clinics and those who are out of school so that they can go for the HIV testing services? And again, since you know the stats about women being infected, what about men? Does it mean that less men are infected, or is it that most men do not go for HIV testing services? And if that's the case, I would suggest that we start working on having more men to go for the HTS. And my last question will go to Mrs. Malimabe. I'm happy to find out that you're using these fashionable terms of condom bash, pyjama party, and the likes. And now, actually, to attract more young people to attend this occasion.
Well, thank you very much, program directors, conference chair, Dr. Jorgen Pillay, and co-chair, Ms. Andile Mtombeni, our First Lady, Umama Tobeka Madiba Zuma, and head delegation, HATE's director and organizer of this conference, Dr. Ramni Kalwalia, UNFPA country director, Dr. Esther Muya, UN women here represented by Ms. Kutugu Shongwe and other UN regional heads, the Deputy Chairperson of the South African National AIDS Council, Ms. Steve Letsike, senior government officials, university and TVET college leaders and their representatives, development partners and NGOs, distinguished guests and Heights private and government partners, youth leaders from a range of entities and organizations,
We are doing this, but we're also human beings. Is it fine? Can I introduce the Honorable Deputy Minister, Mr. Mtutuzi Manana? Thank you, ma'am.
Aye, bandabacha, aye. Aye, bandabacha, aye. Well, thank you very much, program directors, conference chair, Dr. Jorgen Pillay, and co-chair, Ms. Andile Mtombeni, our First Lady, Umama Tobeka Madiba Zuma, and her delegation, Heights Director and organizer of this conference, Dr. Ramni Kalwalia, UNFPA Country Director, Dr. Esther Muya, UN Women, here represented by Ms. Kutugu Shongwe and other UN regional heads, the Deputy Chairperson of the South African National AIDS Council, Ms. Steve Letsike, senior government officials, university and TVET college leaders and their representatives, development partners and NGOs, distinguished guests and Heights private and government partners, youth leaders from a range of entities and organizations, members of the media, and of course, young delegates from universities, TVET colleges, from schools, and of course our out-of-school youth for whom this conference has been organized. Good morning. Sanbonani, Molweni, Goeiemorgen, Lochani. Great. Well, it is a profound honor for me to be officially opening the so well-attended Heights National Youth Conference this morning. As the first of its kind, this conference is an important milestone, not only for the higher education and training sector, but for the whole country, because never before have we had the opportunity to bring together youth from schools, universities, colleges, and out-of-school youth to share their experiences of working in the field of HIV and discuss their challenges and best practices. I am proud to be standing in front of you today to affirm that it is indeed the higher education and training sector that is putting into practice the vision of bringing our young people together to discuss very pertinent issues that affect them. Esteemed delegates, although we've come a long way as a country, but we must admit that South Africa still has deep social problems that we need to address openly and eventually overcome. I am constantly confronted with these in my line of work and often reminded of the intersectionality of the issues that our young people are facing. The most pressing challenge is probably the one of poverty. As you may be aware, a significant number of students come from impoverished families and communities. Many of our female students find themselves in financially unstable situations, having to balance their tuition fees for their education, while also trying to find funds to cover their accommodation and other living expenses. These students often take care of their families, as a large number of them come from vulnerable families, but also have to attend college and university. Many of them are first-time entrants to universities and colleges in their families, but as well, they become the first ones to obtain either university or a college qualification. So there is immense pressure on them, pressures which lead to female students in particular to engage in sex work or relationships with older men in order to cover their study fees and living expenses. We often hear about the so-called blessers or sugar daddies in the news, and we see it happening in our communities. We see it happening at our campuses, where older men would come with their very expensive cars to pre-own our young female students, of course taking advantage of their socio-economic vulnerabilities. So it is happening, and it is something that we have to confront and deal with more decisively. The fact that we shy away from talking about these problems in our society because they make us feel so uncomfortable leaves our female students in relationships of dependence on men that often lead to young women feeling disempowered to negotiate condom use and take care of their own health. So because we don't talk about these things, our female students are not as empowered to actually challenge these older men or even persuade them to actually use a condom, because there's so much dominance. When a person has financial power over the other, he then tends to want to dominate. And as a result, female students become so vulnerable. So there is no room to negotiate for condom use. And that's when the problem starts. Colleagues, we have to acknowledge that the 2016 nationwide student protests on issues of gender-based violence in South Africa have really called for action and leadership. In October 2016, I directed heads to work on establishing a technical task team which will investigate ways of addressing issues of gender-based violence in the higher education and training sector, and also look at the possibility of developing a policy framework that aims to provide practical guidelines for all our universities and colleges on the prevention of gender-based violence at all higher learning institutions. Members of the technical task team are in attendance at this conference, and they will be able to share some insight on the work they are doing in this area of gender-based violence. Esteemed delegates, I would like us to acknowledge that there are also a number of other difficult and important social issues in our sector that we need to address jointly. Besides the issues I've mentioned, or the issues that we all know of transactional sex, gender-based violence, and financial struggles of our students, we need to look at the challenges of drug and alcohol abuse, stigma and discrimination against people living with HIV and members of the LGBTI community, as well as the lack of youth-friendly services in some of our healthcare centers and clinics, amongst many other things. These social drivers make our youth enormously vulnerable to HIV, TB, and sexually transmitted infections. And this is why we need to look at HIV as a social problem and a challenge that needs all of our commitment. The AIDS program is built on the belief that it is our empowered and educated youth that will bring about change in this country, especially when it comes to lowering the rate of new HIV infections. It is for this reason that we thought we should organize this conference as an opportunity to bring together various government departments, academics, young people from all walks of life, to build on our experiences and lessons, and thereby find new ways to deal with issues of HIV and social drivers of the pandemic. Of course, what makes this conference unique is that it does not only focus on biomedical research and new innovations in the field of HIV testing, treatment, and care, but has a specific focus on the social and structural drivers of the pandemic. Our national and international presenters and workshop facilitators will look at emerging good practices in the fields of peer education and community engagement programs, as well as academic initiatives and curricula, ethics, and protection of human rights. This conference is expected specifically to look at issues of stigma and discrimination of marginalized groups and the LGBTI community, and the use of modern technologies and interactive methodologies such as theater, radio drama, and social media to address challenges of human rights and social justice. The next 2.5 days should be a learning curve for all of us. It is our academics and political leaders that should first and foremost listen to our youth. But our young people should equally give opportunity to listen to those who are policymakers as they outline some of the experiences and lessons learned over the years. As we gather here today, we want to listen to our young people. Our young people must be very critical, they must engage their leaders, they must tell their leaders what it is that they think should be done in order to resolve the many challenges that confront us. I wish to remind all of you that the next 2.5 days really present an opportunity for you to raise your voices. To raise your voices about the social challenges and injustices that you face every day. To discuss your dreams, your visions, and ideas. And as I said earlier, to critically engage your leaders. We are grateful that our country's Deputy President, who's also the chairperson of the South African National AIDS Council, Mr. Ramaphosa, will be joining us tomorrow. And he has committed to an open conversation with our youth. He wants to listen to you. He wants to be engaged. He wants to hear what young people think about their future. So the slogan that says, "Nothing about us without us," is finding more resonance in this case. Esteemed delegates, let me acknowledge the Higher Education and Training HIV/AIDS program, HAIDS, and its leadership for really organizing this conference. As we know, this program, the HAIDS program, was designed to eradicate the impact of HIV, STIs, TB, and also aiming to strengthen general health and wellness issues in the higher education and training sector. As part of an increasingly comprehensive HIV, TB, STIs, and other healthcare and support mitigation programs in the post-school education and training sector, HAIDS currently implements various comprehensive health, wellness and prevention projects and programs in partnership, of course, with a range of strategic public and private role players. We're incredibly proud of the success of this unique program, for it has shown that dedication and leadership can lead to concrete results. In 2016 alone, the AIDS First Things First HIV counseling, testing, and general health and wellness program offered more than 165,000 students the opportunity to participate in testing and screening for HIV, TB, sexually transmitted infections, and general health and wellness. Further to this, over 1,500 academics and university and TVET college staff underwent training in the curriculum program, whilst over 192 campus and community radio station journalists have participated in the unique AIDS Future Beats radio and social media program, reaching more than 720,000 young people in 6 provinces of South Africa with regular HIV prevention programs. It is now 16 years since the AIDS program was established in the higher education sector. As South Africa's nationally coordinated, comprehensive, and large-scale effort designed to develop and strengthen the capacity, the systems, and the structures of all our public universities. And for the past 2 years, our public colleges have become part of this program. Being a leading HIV prevention program in the country, I believe AIDS is perfectly equipped to lead this first National Youth Conference, and we congratulate you for this. On behalf of our ministry, the Ministry of Higher Education and Training, I wish all of you a fruitful conference. You must have robust discussions, honest discussions, which will guide us on how we can go about addressing some of these presenting challenges. Coming out of this conference must be some new, innovative, and inspiring ideas. Young people have gathered, so you should not wander about on the beach and do all of those things. There will be time for that, I'm sure, Dr. Lwale, so that our young people can really stretch, go to the beach, but at least a bulk of the work must happen here. Discussing, trying to find lasting solutions to the many challenges that I've outlined. So it is interesting that indeed we have all come here in numbers, and we thank you because you could have otherwise attended many other things, but you came here. Yes, I've seen it. But you have come here to really engage amongst yourselves, but engage sector leaders as well on these and other challenges. Colleagues, once again, to the organizers of the conference, thank you very much. It could not have been easy. Ngiyathemba ningishayela ukuthi ngiyohlala phansi. Ngingayivala i-conference ngingakayivuli. On that note, it is with utmost privilege and honor to declare this first AIDS National Youth Conference officially opened. Thank you very much.
Thank you so much, DM.